I am so excited to welcome to the podium Dr. Rupa Basu. Dr. Rupa we're very honored to call her part of our advisory committee at the Nurturely advisory team. She is currently the chief of the Air and Climate Epidemiology section at the Office of Environmental Health Hazard Assessment of the California EPA. She has published extensively on research examining temperature and air pollution on health outcomes, including mortality, morbidity, and adverse birth outcomes, while identifying vulnerable subgroups. She has worked at the US EPA. She obtained her PhD in epidemiology from Johns Hopkins Bloomberg School of Public Health. MPH was from UCLA School of Public Health. She's currently collaborating with extensive external organizations, including Scripps Institute of Oceanography, Kaiser Division of Research. She's served as a referee for health journals and been on several scientific advisory panels. Her accolades go on, but we're really excited to have her as really an authority, and not only in the research world, but a real advocate for this work. So once you know Rupa, you'll be able to look up her name and see all of the ways that she is getting this work out there, publicizing the importance of perinatal health equity, racial equity, equity for pregnant people around the globe, as we're thinking about climate change. So please join me in welcoming Dr. Rupa Basu.
Thank you so much to the Nurturely team for having me here today. It's really my pleasure to present some of the work that we've done at our office. And I think it's just so much better in person. So I really appreciate this invitation. So the title of my talk today is Ambient Heat Exposure and Adverse Birth Outcomes. A lot of the work that we do tends to be around ambient heat exposure, but the other half is air pollution, which Dr. Sandy Ha will be presenting next. So you've probably seen headlines from following heat waves. These are more like case reports. There's been headlines all throughout the world now. Probably the most alarming in our lifetime was the 2003 heat wave, where in Europe, where 70,000 people died following that heat wave. So this first slide I want to show is not just to show that we know that there's a strong correlation between carbon dioxide and temperature. And the hottest summers that we've experienced are actually in the last 10 years. It feels like the last summer gets hotter, and then we think it's not going to get any worse. And then the following summer is even worse. And then on top of that, we might get a wildfire or two. So that's one thing. But the other thing is, when we look at emissions, we can actually limit the emissions and reduce those. There's nothing that we could do about temperature, but if we know what's causing these temperature increases, that's where the policy comes in. I think Emily's already showed us a similar slide, and so I won't go, I don't think I need to explain this again, but I do want to say that regardless of, this is the climate gap, and regardless of whether we're talking about global exposures, national, or since I'm working for the state of California or state, we see this all across the board. It's the largest emitters are not the ones who are most affected. And so that's really important because usually the people who are most severely impacted by climate change are the ones who can also not act upon it. So it seems like it's kind of this double barrier here, that you are not only not the biggest emitter, but you're most impacted, and you're not in the place to do as much about it. So currently, the Centers for Disease Control, they say that there's about 700 deaths from heat-related illness in the U.S. It's similar in males and females, but the point I want to make is that this number is severely underreported. And the reasons why is because there's no systematic definition for heat wave. So this really varies by local health department or region. In California, we've talked to some of the local health departments, and Some of them don't even know how they came up with these definitions. They've been the same since the 1970s. We know there's been quite some change since then. And the vulnerable subgroups are all different. And this is important because in heat advisories, for a long time, it's been just the elderly that have been included. Now we have so much research done on pregnant women, but they're often not included in heat advisories. So we have to just think about that for a little bit, that if they're not included, then they don't know that there needs to be any intervention done, and therefore there's no prevention that could be done for particular groups. So just an example of a heat wave could be 98th percentile of temperatures in a specific area. That's really important. They're so localized for 2 or more days. And there's differences between daytime and nighttime thresholds, which is really important. California tends to have, now we're having hotter temperatures at night. So people aren't able to cool down or acclimate. And heat-related illnesses or deaths are only reported during heat waves, which in epidemiology we call our surveillance bias, or when no other cause of death is suspected. So just imagine, so these cardiovascular deaths that we see are not connected to the heat. And so those don't get counted. So it's just these ones that we're not really sure what happened, but, oh, okay, there was a heat wave. So probably it is a heat-related death or illness. So this is one of the main points I want to make. It's really important to look at other health outcomes. Don't just look at heat-related deaths and illnesses. And most of my talk, the rest of it is going to be on the adverse birth outcomes, which I've highlighted here. But we have found so many other associations, emergency room visits, hospitalizations, deaths from heat-related dehydration and illness. That's one of the main causes. But we also have to look at cardiovascular and the subgroups of those, such as heart attacks, respiratory, such as asthma, diabetes, mental health. That's kind of a newer area that we've been exploring: liver and kidney diseases, infectious diseases, gastrointestinal. And the adverse birth outcomes that I'm going to talk about in the next few slides: preterm delivery, low birth weight, and stillbirth. So as I mentioned earlier, the vulnerable populations for heat and health impacts are the elderly. These are just some of the high-risk populations: the socially isolated, pregnant people, young children and infants, outdoor workers such as farm workers, using some medications such as beta blockers, which are used for heart disease, and antidepressants. Remember, I said there's an association between heat and cardiovascular diseases and mental health. And so if you're taking these during a heat wave, or even just during the summer, it could cause some interactions. Then some building infrastructure, such as living on higher floors without air conditioning typically, or building materials that are used. Poverty, which is measured in so many different ways. Young athletes, this is a group that are often considered healthy and not at risk, also not included in heat advisories for the most part. So I mentioned some of this already, but just in California, I borrowed these next couple of slides from my colleagues over at the Scripps Institute of Oceanography. They work with the California Nevada Applications Program, or CNAP. And what you can generally see is the blue lines are showing nighttime heat or nighttime temperatures, and the red is showing daytime temperatures. You can see that there's more red on the left and more blue on the right. So there's that shift where the nighttime temperatures are getting warmer. It's also what we've seen typically, I guess, since 2006 in California, is that heat waves have become more humid. That's not something that we generally see in California. So if people are not acclimated to that, the health effects could be more severe. And then another trend that we're seeing is that if you look at the graphic on the left versus the right, is that coastal areas are more impacted. In California, coastal areas are most populated also, and tend to have the more diverse populations as well. And if you look at Northern California particularly, a lot of those areas don't even have air conditioners. Not that that is like definitely not the solution, because we still see health impacts with air conditioners. But so there's just that less, the ability to mitigate is less in those areas just because we haven't typically had those temperatures. And one more thing I want to say that is if there's a temperature that's on average 80 degrees, may not sound like a lot, but in a city such as San Francisco, that's pretty mild temperatures, that could constitute a heat wave. Whereas a place like Sacramento, that's more inland, experiences these temperatures more, you may not see those same health effects in those areas because people are more acclimated. So typical summers will be generally warmer in California, but, and this is something we're going to see all throughout the world and throughout the country. There's predictions that it'll be about 4 to 5 degrees warmer. So if you think about that, that doesn't seem like a whole lot. Like, okay, well, maybe we're going from 90 to 95. This is an average temperature. So sometimes we've already seen this. We're going above 100 in places that we've never experienced these types of temperatures before. And because of this, we're going to see more heat-related deaths, particularly in urban areas. And there is a lot of migration in urban areas. And that heat wave that I mentioned in 2003 in Europe, that was mostly impacting urban populations. And then not only is the population over 65 increasing, but the mortality, it's a rate is also increasing by tenfold by the 2090s. And a lot of this is due to climate change. So now I'm going to get into some of the epidemiologic studies that we've conducted. This study was on temperature and risk of preterm delivery. It was published in 2010. And I have to say that at the time, there was a lot of skepticism. I got this idea because I've been reading a lot about thermoregulation, and I had a couple of pregnancies myself and realized, well, I guess you could see now I have like 5 layers and I'm always cold. During my pregnancies, I was like, oh, something doesn't feel right. I'd be in like colder climates and still feeling like warm. And I realized, okay, I'm not able to thermoregulate. So let's just, since we have this data, let's look at it. And what we found is, I don't have to look at the numbers so much, but more the trends. So the overall result was that there's about a 9% increase in preterm delivery during the warm season in California. So this is not during a heat wave. This is just what we've already experienced in the past. So it could include heat wave periods, but mostly it's just general background temperatures over the summer. And the main thing that I want to point out here is that all pregnant people, regardless of race or ethnic group, are at increased risk. But you see that there is this quite shocking disparity. First, I want to point out that when we looked at elderly populations in California, we found that there was about a 2.3, 2.6% increase. You could see that for pregnant people, the risk is much greater. Also, for between, and this is how it's coded in our database, white, Black, Hispanic, and we were able to put an Asian population together, which I realize is still pretty diverse. But still, you could see that there's almost over a 2 times greater increase in risk from temperature for preterm delivery for Black populations. There's also a greater increase for Hispanic and Asians compared to white. You see a similar trend in age or by age group. Younger people generally have higher risk than older, but still it's a pretty, you can see everything is above 0 in this case because we're looking at percent change, and everybody is at risk. This is a very high risk population. So with the data set that I used, it was just a California birth certificates. We are very limited with there's so many other variables that I would have liked to looked at. And then I know that the Kaiser Division of Research, they have more data and more maternal risk factors that we could look at. So I collaborated with them, And some of the risk factors we could look at was smoking status, alcohol use, pre-existing and gestational diabetes, pre-existing or gestational hypertension as well. And this is a lot of results all at once, but you could see compared to what we had seen before, the risks are much, much greater. So the behavioral factors such as smoking resulted in about a 30% increase, similarly for alcohol use. But the comorbidities such as diabetes or hypertension, and some of these risks we know are also vary by race, ethnic group, also vary by age. It's important to just, we couldn't look at the double interaction between age and all of this, but you could see that it would be pretty, we've got 85% increase and a 45% increase. And we also saw associations with preeclampsia and then gestational diabetes and hypertension. So the way that I chose these birth outcomes is really just the data that we had. And so if I had other outcomes, I would definitely look at them. But this is also, more recently, we could look at stillbirth or fetal death in California data sets. So we looked at the entire year in California and various lag times. I know it's a little confusing, but sometimes it takes at least 2 days for a fetal death to be recorded. So this is just lag 2, 3, 4, 5, 6, and then cumulative lag. Sometimes we know that heat or temperature is more of a cumulative lag. And right off the bat, you can see that the entire year, the data are really driven by the warm season, which is May through September. Sometimes I include April or October, depending on the data. And then the cold season is completely has the opposite association, where there's either no association or not statistically significant association. And then you could see that not only was it the best fit for the model, but it was the greatest risk was the cumulative exposure of 2 to 6 lag days. So that's important because it's not just one day sometimes that would have the strongest impact. It could be that you need a full week. We saw the same thing with preterm delivery. And by race, ethnic group, age, education, and then this is infant sex, you can see that there's not as much of a pronounced difference for stillbirth. And also for age, there is a dose response, but actually in the opposite. I'm sorry, this is the same direction. So the younger mothers have greater risk. The next one that I'm going to show you, the term low birth rate, is the opposite. I got confused. So education is similar, maybe a little bit greater risk for less than a high school education at the time of giving birth. And males, maybe slightly greater difference, but nothing too, not too much of a strong difference. So the next study that we conducted was temperature and term low birth weight. And this time we combined areas by climate zone. And these are just areas that the California Energy Commission put together. They're based on weather patterns, energy use, and other factors related to county or to climate. We thought this was a better depiction of what's going on than just looking at overall county risk. And you could see some of these climate zones are really large, but they're less populated. So if you look at, I have in the little box, Los Angeles County, it's so diverse and also it has so many different microclimates. And I think this captures that better because in LA County, we've got 3 or 4 microclimates and enough of a population to look at those separately. So looked at different exposure windows, and for low birth weight, it's different than preterm birth or stillbirth. Those were very short-term effects, which if you think about the public health response, you have to be really quick because if it's only a week, you have to prepare beforehand. It's not really like, oh, we've got, summer's coming up and, oh, well, now it's kind of too late. For low birth weight, what we're seeing is there is a short-term risk, but there's also a longer-term risk. And this happens because of the mechanism. I'll get into that a little bit later. But what we're seeing is the greatest association this time is with the full 9-month gestation, and largely driven by the 3rd trimester, so at the very end. And when I tried to look at the last month or the last 2 weeks, you could see that there's still an increased risk. So some of that is coming from that time, but it's really that last trimester. And since we looked at term low birth weight, these are all full-term infants. So just looking at different categories, these are the only variables that we could look at with our data set. Is the race, ethnicity. You couldn't see too much of a clear pattern here, but you still see that Black people in this study had the greatest risk out of all 4 race ethnic groups. The age, this is, part further than the 40 plus, you could see that it has the opposite trend. And it kind of goes along with this too, where more educated people have greater risk here for low birth weight. And again, male infants, slightly greater risk. And being born during the warm season, remember it was that 3rd trimester, so at the very end, had the greatest risk. And so again, we're seeing a very strong association with the warm season, regardless of the birth outcome that we're looking at, and regardless of whether it's a short-term or a long-term exposure. So from 2007 in the California birth certificate data, we are able to look at some of these other factors that I was able to look at it with the Kaiser Division of Research as well. But the data aren't that complete. So I couldn't look at things like, so we have cigarette use here. I think it's a little bit off, so sorry about that. The top is a little bit off. WIC, being in the WIC program, or program for women, infant, and children, seemed to actually work the opposite way. And then in that, I was thinking that people who are on this program would be at greater risk, but it's actually slightly the opposite way. And the reason for that is because maybe the program isn't really reaching out to all populations that are at greatest risk, because there's this cutoff. And so there's not really, I think that needs to be expanded, or programs like that. Cigarette use, you could see that the confidence intervals are pretty large. Birth weight, body mass index. I was actually expecting, just based on my hypothesis, that that tissue can store heat better. I thought overweight, that would have been a greater risk, but it's actually underweight. Maybe that has to do with diet and nutrition, but the underweight population had the greatest risk. So just a little recap. I know I went over a lot, but the vulnerable populations are, depending on the outcome, could be Black, Asians, Hispanics, younger age. Sometimes with the birth weight, we actually saw older age, hypertension, diabetes, alcohol use, and smoking. So I mentioned that there was a lot of skepticism with that first study. The great thing is that after that study was published, I have seen studies conducted all throughout the world where there's similar results. So that consistency is really important, because now people are like, oh, maybe there's something going on. Maybe it's not just that one study or this one, like one data set that shows that there's an association. And so another important part of this is that I was one of the co-authors with 3 other physicians. So by publishing in a clinical journal, this reached a different audience than I usually publish in epidemiology or environmental health journals. And I realized how important it was to not only have this consistent finding of the systematic review, 68 studies. This is for air pollution, and heat, with all of the birth outcomes I talked about. But now, all of a sudden, this reached this wider audience. Now, like, all of a sudden, the American College of Obstetricians and Gynecologists, they're reaching out to us. We're like, oh, this is great. This is what we want. We want some interventions, because if you can reach that clinical side, then there's going to be some differences in outcomes. Of course, that's not the only population we need to reach, but still, it's another population. Rather than just keeping it in this little scientific bubble of epidemiologists and biostatisticians, for example. Some of the symptoms that we see from a heat exposure and adverse birth outcomes are very similar to pregnancy. There's nausea, vomiting, headaches, dizziness. So I think what happens is many times there's no connection made between the heat and these symptoms. It's just like, oh, okay, well, you're pregnant, you're fine. But I think we need to pay more attention to this, because what could happen is that any of these symptoms that are caused from dehydration could lead to oxidative stress and inflammation, which produces oxytocin in the body. And when oxytocin is released, that is really telling the body your baby is ready, or your fetus is ready to be delivered. And immediately there's decrease in uterine blood flow, which could cause decreased fetal growth. And that's important because when I was talking about the birth weight, we see that here. And there could be induced labor prematurely sometimes. Now, I did kind of very quickly go over some of the disparities that we saw in our studies, but I didn't talk about the reasons that we see these disparities. I think this is important because we can't address them unless we talk about these reasons. Well, I know Emily already told us that regardless of whether we see this exposure or not, there's already a disparity with the birth outcomes, okay, by race and ethnic group. That's probably the most pronounced thing. But on the other side, without even these health outcomes, if we just look at the exposure, so there's greater exposure to heat, there's air pollution in certain communities, which I've seen labeled as environmental racism, environmental justice. There's more power plants in these areas, fossil fuel combustion, freeways, urban heat island, which means there's more absorption of the heat, less green space. There's been so many studies to show that there's more adverse birth outcomes and health outcomes when you're living in these types of areas. And this is all stems from historical redlining. And then the health outcomes themselves. Some of the reasons are lower socioeconomic status. For example, if air conditioning is one of the ways to cool down, not being able to afford it or not having it because it's just too expensive, or maybe during a wildfire, relocation might not be feasible, or if there is a heat wave or a heat event, people still have to work. So that is one of the issues. There's less access to healthcare for some populations. I know sometimes in the last few years that has gotten a little bit better, but there's still many people using the ER for primary care. But I think the most important thing is that even with the same access to healthcare, there may be differential treatment just based on skin color. So that is the reason I bring these up, is because these are all addressable issues. Everything that we've seen here, all of these outcomes are preventable. So these are some of the ways that we could, I don't want to say easily prevent these, but there are tangible ways that we can prevent these things. So I just want to talk about some of the ways that our studies have been used. Again, it's so important not to just keep it in this research world. So we're part of this big effort from California, California's 4th climate change assessment, which came out at the same time as a US EPA's climate change assessment. This was released in 2018. We're working on the 5th assessment right now, which will probably be released at the end of 2024, is what we're thinking. But the reason we decided to publish a separate one from the, not only is it only very connected to politics, which I won't get into, but it's also very different. California has so many microclimates, different populations. We're very populated in certain areas which are experiencing so many different ways of, I only talked about heat, but climate change impacts. So there's the temperature, but there's also sea level, snowpack, heavy precipitation events, which we've seen so much. This was published back in 2018. We didn't know what was coming. But then we also have drought and exceptional drought in many areas, and wildfires like we've never seen before. I grew up in California, and just in the last 5 years, we've seen more wildfires that have affected populations, particularly urban populations, than I've ever seen in my lifetime. And it's becoming the norm, which is quite scary. All the things that I just showed you, those associations with any of these, I mean, particularly I study more the temperature or the wildfires. Those associations are all so much greater with a heat wave or with a wildfire event. So if I'm presenting or Dr. Howard will present some air pollution studies with the wildfire, those associations will be even greater and have the ability to impact more populations. And that's important because it's not just the level of exposure, but it's also the fact that it's spreading more quickly. Just to give an example, I know I kind of showed something similar before. There's a 4 to 5 degree increase by mid-century, but by the end of the century, there's models to show just from greenhouse gas emissions increases. And I have to say that all of these models so far have been actually really underestimating the risk so far. So we're seeing a 9 degree Fahrenheit increase by the turn of the century in these models. But then when we've updated models or seen other people updating their projected models, we're already seeing much greater increases if we stick with what we're doing right now. And then some recent bills in California. I think this is so important after doing so much work. So there's Momnibus, which is not to be confused with the federal Momnibus. This is the Senate Bill 65 that passed in 2021 by Nancy Skinner. And it's just to look at maternal and fetal health outcomes, particularly for communities of color. And this is so important because a lot of these bills were based on epidemiologic work and other scientific work. It's taken a little bit of time, like over 10 years to finally show, maybe even 20 years to show that's when the bulk of this research has been done. But we're getting there. At least we're making some progress. Another thing is this AB 2238, which we've been talking a lot about in California. The last 2 bills just passed. These are just examples. Extreme heat, where we're going to have a statewide extreme heat ranking system. So not only do we have a ranking system, but we're also going to label heat waves. The reason for this is, I guess the background is to show that these are important. Remember, I was talking about how underreported heat-related deaths and illnesses are? Well, maybe if we show for prevention too, like a level 1 is coming versus a level 5, or a red versus an orange. And, maybe we can say, this is what's going to be coming. We can prevent some of this stuff by adding this to the heat advisory system. That's our hope. Also, by naming them later on, if the wildfires have been named, but the heat waves are not. So later on, when we're referring to them, it feels like they're kind of like, just like, oh, well, yeah, that heat wave back in, 2020. Yeah, it was a bad one, but, it's hard to refer to it because especially if you have multiple heat waves in 2020, what are you going to do? So this is part of the reason for this. We've had a lot of conversations before we got to this point, but haven't developed that yet. But we're starting to do that. And then for 2240, it's for perinatal and infant children's health specifically. And I just have to say that from my experience, probably a lot of other people's too, I think pregnant people, infants, are the last to, even if you've studied so much and you have so much evidence, it takes so much more for, a bill to get passed for this population. So I feel like this is huge, and, there's so many reasons behind that. Mental health, of course, is another area, but it really is often overlooked. It's still, we've got a lot of work to do in that area. So just the last couple of slides, I said I would bring this to this group, is that I just presented some of the work that we do at our office. We do a lot of other work too, which I just wanted to kind of highlight here. Some of you might be familiar with some of our other reports, such as we have Calvin Virus Screen, for example, which I think a lot of people have used. And then this is my section. We do have a couple of openings, oil and gas toxicologist and a research scientist coming up. So that is it. Thank you so much for your attention. And I'll leave it there. Oh, did you want to do questions? Sure. Oh, yeah.
Thank you. That was really great and interesting talk. I'm Veronica Irvin from Oregon State University. And what might be some reasons that perinatal and infants have been low priority in some of the outreach for climate change or for some of the wildfire smokes?
Yeah.
It's surprising to me, and especially since you've had a decade of research coming out of your office.
Yeah, and that's just our office. And before that, there was other work on air pollution and so much more. I think it's just a bias. I mean, really, that's what it is. So, women, children, and then when you add in the race piece too, I think all of these things were the last ones to, get included in anything. So it's actually like, it takes so much more work to get that legislation or anything passed. I mean, even just publishing a study, I think there's a publication bias, like, oh, that couldn't be true. Let's not even, this is made up, or, something like that. When you get more and more research showing the same thing, and it takes so much more research to show the same thing. Like, it's interesting. You could just have a couple of studies for another group. But when it comes to pregnant women, oh, wow, we need so much evidence. And it's still like, maybe this isn't really true. So it makes no sense. But that's just my experience, whether we're talking about climate change or, other epi research. So. Okay. Other questions? Oh, yeah.
Thank you, Dr. Basu. I was wondering, in that last legislation you mentioned that was passed specifically for infant and children's health, do you know, is that funding towards harm reduction, for people's home improvements? Is it funding towards more research? I'm just wondering what that bill is actually addressing, given that you shared so much of this is preventable.
Yeah, that's a really good thing to bring up, because it just passed. It's still even though it's there's a mandate now, there's still room to develop those ideas. So it's not like we have to stick to only this part of it. We could do research is important, but of course, just doing the research is not going to get us anywhere. So it's also then, we want to increase advocacy, increase, other policies. We want to kind of make sure we hit all the different points. Research is almost like just the background, the backdrop, and then everything else needs to kind of follow from that. So.
Thank you so much, Dr. Rupa, for your amazing work. I was wondering if, do you think it would be possible to research interconnections between maternal mental health and extreme heat? And do you have any thoughts on what the results might be?
Yeah, that's such a great interconnection. So when I was talking about pregnancy and being overlooked, so mental health is also overlooked. So now it's like this layer, you get the pregnancy, mental health, the climate change, the race. It's just so many different pieces. But we have done some studies on heat and mental health, also air pollution and mental health, and found some associations that were pretty strong there also, with schizophrenia, with depression, with other psychotic and neurotic outcomes, also suicides and homicides. And that wasn't for pregnant people specifically. We don't have the data to look at maternal mental health. See, this is the big barrier, because I've been wanting to do this. So in the birth certificate data, they don't have anything about mental health. Sometimes it might be listed as a pregnancy complication, and that's just very dependent on the practitioner, whether that's included or not. So this is a problem. If I think that would require either data collection or going to a hospital back, such as Kaiser or something like that to get that data and do this kind of study. So, but definitely of interest.
Other questions? I have two questions.
Oh, okay.
One question I was really interested in was this really heightened risk for younger parents in terms of preterm birth and low birth weight during heat waves. And I was just curious because that's, the opposite of what we usually see in terms of who's usually at risk. Usually older parents are at higher risk of these adverse birth outcomes. So was that just because the odds change in risk was so different from going from this really low risk group to this really high risk group? Or I guess, what does the actual absolute risk look like in terms of, I don't know if you can speak to those data at all.
Yeah. So with the younger people at greater risk, we're thinking that part of it has to do with some of the mothers in this population were very young. Like we saw, I think the age group was like starting at like 9 to 45 or something like that. So at that point, maybe, the body is not ready. And there's so many of the other factors too. The education level is lower because just because at the time of giving birth, I haven't had a chance to get past, high school or even less. So that's part of the risk. Part of it has to do with choice, not having choices. That's a big thing these days. I think also there's sometimes it's a marker for socioeconomic status. And so because of that, there's like less, ability to speak up and take care of your own body and needs. So I feel like maybe also the healthcare is not as good. Diet and nutrition may not be there. So there's many factors. It's just like, I feel like this age is just like this tip of this iceberg. And there's so many other factors that it really like represents. And the same thing with the race. That's the only variable that we can look at, but it's really like so deep, like if you really look at it. So there's many reasons for it.
Thank you. The other thing I was really interested in was your, noting that oxytocin might be the mechanism underlying heat-related preterm birth. And I was curious if you could speak to that a little bit more in terms of what do we know from the data and, at what levels, because we think of oxytocin obviously as being a very important and positive part of birth. And I had never seen it framed in this, kind of as a byproduct of extreme heat and potentially causing harm in this instance.
Mm-hmm. Yeah. So oxytocin, that's kind of like when those levels increase, like that's the trigger to say, oh, it's time to deliver. So that was my point there, is to say that if the heat increases almost artificially, and it's not really the heat itself, it's the core body temperature that's increasing, right? So not being able to thermoregulate, not being able to cool down, not taking precautions because you don't know you're supposed to be taking precautions, but all of those things, the oxytocin increases, and then that's why there's delivery. So sometimes there's something that's similar, Pitocin, to induce labor. That could also happen, but it's not. It's a natural thing, this is how your body knows it's time. This is, let's increase the contractions, decrease the uterine flow. It's time. But when it's artificial, like it's, something that's happening to your body that shouldn't be happening, that's when you have the problems, right? So that's kind of my main point there, is that's when you see the preterm delivery or I didn't talk about small for gestational age or term low birth weight, stillbirth, all of those things could happen. So.
Awesome. Thank you so much. I really appreciate that explanation. Everyone join me in thanking Dr. Basu one more time.